Yeah, dear colleagues, now it's 5 o'clock p.m. and I'm happy that we restart our webinar in the west section of the ENS after the summer. A very well-known expert in neurosurgery is
Veit, your connection is pretty bad.
University of Mannheim in Germany.
Veit, can you turn off your video maybe? Then your bandwidth may improve.
Yeah, turn off the video. Okay. So, the very well-known speaker. It's
Veit, your video is still on, so perhaps you can turn it off so we can hear you better.
From the University of Mannheim. As bad, so I think Nima should start right away.
Okay, no worries. So thank you very much for the introduction, Veit. For those who couldn't hear it, my name is Nima Edminan. I'm from the University Hospital in Mannheim. I'll be talking about unruptured intracranial aneurysms, pathogenesis management, and unresolved clinical questions. Anna, can one see my screen?
Not yet the presentation.
Ah, I'm sorry, I have to hit this share screen again. Okay, this should do. So thank you again, Veit Rode, for inviting me to talk about unruptured intracranial aneurysms, and thank you to the ENS CV section. The prevalence of unruptured intracranial aneurysms is about 3 to 5%, which means that about 15 million adult persons in Europe are carriers of an unruptured aneurysm. As you know, the pathogenesis and also the disease course, and I refrain from the term natural history because usually there is no natural history in civilized countries, but I'll get back to that later. But the disease course remains uncertain. That means if an aneurysm is detected, it can remain stable for long periods of time. It can grow and develop irregular morphology, during which it is already prone for rupture, or it can rupture during growth. And as you know, the corresponding disease, subarachnoid hemorrhage, has a devastating clinical prognosis with a mortality of 30%, which is especially serious in view of the young age of the patients of about 52 years. As you know, we have nowadays very established treatments, meaning endovascular techniques, but also microsurgical clippings. Both approaches have their pros and cons, and they're highly effective, but they do carry risks. So it is important that we continue to prove our understanding on the pathogenesis of unruptured aneurysms, which may also result in novel strategies for prevention of aneurysm rupture, because probably we cannot treat every aneurysm depending on size, etc. I think it is fair to say that unruptured intracranial aneurysms are a unique and complex entity, and they differ distinctly from ruptured aneurysms. So you cannot deduct studies from ruptured aneurysms, for instance, IZ, to unruptured aneurysms in general, but I will get back to that later. So first, let's talk about the aneurysm formation. Usually, you have a congenital constellation which results in an aneurysm unless you do something against the risk factors in those patients. But in this patient, in this cartoon, this patient has a hypoplastic A1, which then results under the presence of risk factors such as smoking or hypertension into the disruption of the internal elastic lamina, which is the most important structural component of the normal vessel wall to maintain its integrity. And during the continuous presence of these risk factors, but also aberrant hemodynamics, because the flow in this segment is not normal. This segment distributes the blood to the contralateral side as well, so there's asymmetric flow. In the presence of these aberrant conditions, there's already a macroscopically bulge, and then over time there's a real aneurysm. And a real aneurysm, in contrast to the normal vessel wall, is distinctly different, because an aneurysm constitutes, if you will, the failed attempt of the vessel wall to heal itself using scar tissue, and that is collagen 1. So, and you may know this from surgical cases, that you cannot really suture an aneurysm because it's collagen and it doesn't have a muscular layer which permits you to suture, for instance, in normal vessels. So risk factors for aneurysm development, and again, this is not well understood, because these are often data from patients that already had a subarachnoid hemorrhage from a different aneurysm or from case control studies. However, we do know that smoking is a very important risk factor for aneurysm formation. And we know that concomitant smoking and hypertension is even worse. Additionally, we know that genetics may play a role, because if you have a familial history, and that is 2 or more first-degree relatives, then you're at increased risk, threefold risk to develop an unruptured aneurysm. And this is something that we don't know why that is yet, but also female sex predisposes increasingly to develop an aneurysm. And there is a nice study from Mika Koryar's group in this respect, which was published in 2022. So let's move on and talk about congenital factors that result in aneurysm formation. And I think this is something that we don't understand too well yet, but this study from the Utrecht group was able to demonstrate that if the angle of a bifurcation is very wide, that makes a significant difference with respect to aneurysm formation compared to these less wide angles. And the same holds true for underlying aplasias or hypoplasias or fenestrations, that all are congenital risk factors to develop an aneurysm, although aneurysms are not congenital. And if you're really into science of this disease, then I highly recommend Johanna Fersen's very nice review from about 10 years ago, but I don't think we know much more at this stage. And this really shows the different stages on a molecular level of aneurysm formation. So we often get asked by our patients how old the aneurysm is, or how long they had an aneurysm. And I don't think that we can answer that accurately, but we tried by removing aneurysms after surgical clipping, and we used radiocarbon birth dating to birth date the main constituent in cerebral aneurysms, and that is collagen 1. And I can tell you, these were the birth dates. These vertical lines are the birth dates of these about 50 patients, and these horizontal lines were the birth dates of the collagen tissue in those aneurysms. And you can see that there's a distinct dissociation between the age of the aneurysm, which was usually about 5 years, and the age of the corresponding patients. But I have to say that it is not completely the age of the aneurysm, because collagen renews itself, but still we have an indicator that aneurysms are not a congenital disease. And if you look further at factors that influence aneurysm age or aneurysm collagen age, that is again risk factors. So it didn't matter if those aneurysms were ruptured or unruptured, or how old these patients were. There was no association with the actual radiocarbon birth values or the estimated collagen age. However, in the presence of risk factors, the age of the collagen in those aneurysms was significantly younger, which implicated that there's much more increased tissue turnover. Let's move on and look at the pathogenesis of aneurysm growth and rupture. So we should appreciate that aneurysm growth is not a linear function, but it's really a stochastic function, meaning that there's episodes where there's no growth, and then there's an episode which is short and there's distinct growth, and then the aneurysm may stabilize again and again grow and stabilize or rupture at that stage. So it doesn't mean that if an aneurysm has been stable for 5 years, it will remain stable over the next 5 years. So again, under the presence of risk factors, smoking, hypertension, the aneurysm can remain stable, but I think I showed you that on a molecular level, the aneurysm is not stable, and these pathomechanisms continue to do their work. However, if you see radiological growth or even development of an aneurysm sac, like a daughter sac, we know from other groups that at this stage there's distinct aneurysm wall inflammation, and these are inflammatory cells, macrophages, for instance. And if you don't disrupt this cascade, then the aneurysm may rupture. So what are risk factors for aneurysm rupture? Again, those that I mentioned: hypertension, prior subarachnoid hemorrhage from another aneurysm, familial subarachnoid hemorrhage, and aneurysm growth. And there's interesting new data in this respect that allows us to absolutely estimate the risk of aneurysm rupture after growth. And I think this is another important factor that has been increasingly described over the past 10 years, and it wasn't acknowledged in studies such as ISSUA, which is irregular aneurysm morphology. And that, irrespective of any other factor, is a strong risk factor for growth. That doesn't mean that we should treat an irregular 2 millimeter aneurysm, but it is an additional factor, and size only is not the only factor, or location. So speaking of which, of course, and this is data from the phases score. It's not really from our review, but it's from the phases score. And I will show you a bit more details in a couple of minutes to the phases score. But you should know that the reference size is about 5 millimeter. And again, this was after ISSUA a major step forward, because ISSUA said that suggested that aneurysms below 7 millimeter in diameter won't rupture. And location. So middle cerebral artery aneurysms are the reference, and internal carotid artery aneurysms have a 50% risk reduction for rupture, as opposed to ACOM and ACA aneurysms. PCOM aneurysms have the highest risk, and vertebral, basal, and posterior cerebral artery aneurysms are in between. Then geographic location, which is a different thing than ethnicity, because we don't know if a Japanese person that moves after birth to, for instance, Europe, has also an increased risk of rupture, and or if it's really environmental factors in Japan. However, for the Japanese population, we know that the risk is threefold higher. And for the Finnish population, there is more and more data suggesting that the risk may actually be similar to the rest of Europe. One more implication of risk factors, and this was data from our group around Katharina Hackenberg, that looked at actual turnover rates of collagen in aneurysms in relation to risk factors. And if you have hypertension, you can see that this is again the bomb curve from the radiocarbon data. And I don't want to go into atmospheric science now, but let's say that these are estimates for the collagen age in aneurysms. And you can know in hypertension patients, this is nearly on the bomb curve, which means that the collagen is really less than 1 year old in aneurysms. However, if patients smoke and have hypertension, the collagen is even much younger, probably months old. And again, this is a molecular proof that smoking and hypertension destabilizes aneurysms by inducing immature collagen. And this was also examined with collagen stains, where you can see that again in high collagen turnover aneurysms, you see these areas of immature, this yellowish looking and greenish looking collagen stain, which implicates immature and unstable collagen, as opposed to low collagen turnover aneurysms that are dark red. I don't know if you can appreciate it on your screens, but this is dark red and it suggests more stable aneurysms. And it also corresponds to wall shear stress, actually, high wall shear stress. So to summarize our current understanding on the pathogenesis, we know this scenario. This is the most common. Aneurysms form, grow, and if you don't prevent further growth, the aneurysm will rupture, or an aneurysm remains stable over long periods of time and simply grows, or an aneurysm, and this is of course a bit worrisome sometimes, an aneurysm has been stable for decades and then simply ruptures. And I have a case like that I can show you. An aneurysm hasn't been there 3 months ago, but the patient comes back 3 months later with a small ruptured aneurysm. And this is really where we still need to focus our research at. So briefly, PhaSES score as a management tools, and we will now move further towards management of unruptured aneurysms. This is a pooled analysis of the 6 cohort studies, ISHUA, UCAS, and other studies, including the Finnish data set from Seppo Juvela. And this meta-analysis comprised data of 8,400 patients and 10,300 aneurysms, 6 prospective cohort studies, and the colleagues around, and actually, I'm sorry, this is the wrong reference. This was from Jakova Greving in Lancet Neurology 2013, I believe, from the Utrecht group. But this group was able to identify 6 independent risk factors, which were already mentioned today. And size and site were usually the most frequently mentioned risk factors, but now we have additional risk factors. And to cut it short, the PhaSES score is the strongest evidence we currently have, but still there's bias, because bias has occurred in the underlying studies because of preventive repair outside of, for instance, ISHUA or UCAS Japan. So probably this is an estimate to the risk, but not the whole truth. And certainly the PhaSES score doesn't include data such as aneurysm morphology or smoking, and therefore these risk factors were not acknowledged in the meta-analysis, and also familial aneurysms and subarachnoid hemorrhage. This was the impetus for us to develop an additional management tool, and I say additional and not instead of phases, because phases is a rupture risk estimation score, and this is a management score, the UIATS score, which was developed in a large group consensus project. And I can show you the advantage of phases in this in these two patients. So two similar looking MCA aneurysms. This is rather an M1, this is an M2 aneurysm, but phases doesn't differ here. And the 5-year rupture risk according to phases was 0.7% in this patient and 0.9% in this patient. If you look at the underlying epidemiological data in these patients, you see a fundamental difference. This was a 50-year-old male with a previous subarachnoid hemorrhage from another aneurysm. So this was the additional aneurysm, 4 millimeter in diameter, previous SAH as a risk factor, irregular shape, hypertension and smoking, and no comorbidities. This patient is 71 years old, is a female, and had an MRI for screening because of her breast cancer diagnosis. And this is also a 4 millimeter MCA aneurysm. She has a well-treated hypertension, and she has a significant comorbidity, which is her malignant disease, with a life expectancy of about 5 years. So obviously, there is a difference between these two patients, which is not captured by phases. And here, the UITS suggests preventive repair for this aneurysm, and for this aneurysm, patient observation. I think most people in the audience would agree that we wouldn't treat a cancer patient who lives less than 5 years and is 71 years old. Then another management tool, that is the ELAP score, and this is the correct reference by Dan Barkas. And the ELAP score helps you to appreciate the risk of growth of an individual aneurysm. And that's again a meta-analysis, and you can estimate the 3- and 5-year risk of growth according to these risk factors. And I think this is a very good fundament to plan radiological intervals in your patients, because you cannot scan an aneurysm patient every year, at least in our healthcare system. So this helps you to plan your radiological screening intervals. So I've already mentioned that aneurysm growth is a major risk factor for rupture. And this is a very nice study, again, by the Utrecht group from last year, published in JAMA Neurology, that helps you to appreciate the risk of rupture after growth has been detected. And this is data from individual patients that we all pooled. And you can see that the risk of rupture is 2.9% after growth was detected, and it's 6% after 2 years after growth was detected. And again, other risk factors such as shape and location and size. And I think this is a very robust step forward to appreciate the risk of rupture in such patients and to counsel such patients. Then moving now away from whether or not to treat an aneurysm towards aneurysm treatment modality. And this is a difficult topic in the setting of unruptured aneurysms, because there are no real randomized controlled trials in large patient cohorts which were published. So this is data that I'm showing you from the CURES study, which is the only randomized investigator-initiated trial from Canada, from the group around Tim Darceau. And it investigated clipping versus any endovascular treatment. And the primary endpoint was treatment failure. So it's a composite endpoint, and that is already debatable, which includes different factors such as treatment failure, failure to treat the aneurysm, with the allocated modality, so meaning the randomization process suggested endovascular means, but it couldn't be treated in an endovascular way, and that is one element of the endpoint. Intracranial hemorrhage during the first year of follow-up, and a sacral residual aneurysm after treatment. So 3 very different things, if you ask me, but I guess they had to do this for sample size issues. And secondary endpoints were clinical endpoints, meaning morbidity according to MRS greater 2 or mortality at 1 year. I'm sorry for the typo here. And neurological deficits after treatment at 30 days. The trial is still ongoing, and I inquired a couple of months ago regarding the status, and they already reached the sample size, but there's still no difference between the 2 groups, as it wasn't in the interim analysis, which was published 5 years ago, according to data from around 110 patients. So there were 48 patients in the surgical group, 56 patients in the endovascular group. And I think obviously there's a difference between hospitalization duration, which is longer in surgical patients. And however, there was no statistical difference at 1 year regarding morbidity and mortality. According to MRS, you could see that there was a bit of more retreatment, but I mean, that's still early in the endovascular group, and 1 versus 2 is not robust statistics. So it remains to be seen. However, there's more data from meta-analysis that could help you. And I can also tell you that we already acknowledge these studies in the guidelines that I'm going to talk about in 2 minutes. Excuse me. So this is not comparable data between endovascular or surgery. However, this meta-analysis from Aneurysm alga uses retrospective and prospective cohort studies to appreciate risk factors within these treatment modalities. And interestingly, for surgically treated patients, there's a distinct risk reduction in female patients, and this is quite robust. So that was already mentioned in the actual guidelines. We don't know why that is, but coagulopathy and use of oral coagulation increase the risk of surgical clipping. And we know that, of course, aneurysm calcifications increase the risk profile of a surgical case, and the location, meaning posterior versus in comparison ICA. I don't think that these comorbidities can be acknowledged that much, but I think these factors should be acknowledged when you counsel a patient. Regarding endovascular treatment, there's a lot of risk factors, and not many of them are significant. However, also location, but still that doesn't mean that you would surgically treat a posterior circulation aneurysm, but the risk is higher in the posterior circulation, also for coiling. And then it increases with the use of devices, meaning stenting versus no stenting. And it's a 3-fold increased risk. And this is, of course, to be fair, in relation to the complexity of the aneurysm. And this is also seen here. And a wide neck is a strong risk factor for endovascular patients, and should be acknowledged during the interdisciplinary discussion, because this wasn't a risk factor in the surgical data. However, again, this is not immediately comparable, but this is something that you need to talk about when you counsel your patients, that the use of additional devices increases the risk, not only because of morphology, but also because of the devices itself. So to speak briefly about the current ESO guidelines that I was allowed to chair at the side of Gabriel Rinkel within this really great group of interdisciplinary colleagues from all across Europe, and they were recently published in the European Stroke Journal. 5 topics, 13 recommendations at the end, and 15 expert consensus statements. Topic number 1 was risk of rupture versus risk of aneurysm repair. Topic number 2 was risk of surgery versus endovascular aneurysm repair. PICO 3 was follow-up imaging versus no follow-up imaging in untreated aneurysms. Then lifestyle modification and medical management, and radiological follow-up after aneurysm repair. And just to give you a short overview, and I'm not going to go too much into details, again, what I already mentioned, in patients where the 5-year risk of rupture is higher than the risk of preventive aneurysm repair, preventive aneurysm repair should be considered using the treatment modality that is most effective and safe. So microsurgery versus endovascular aneurysm repair. At present, we cannot make an overall recommendation that states which aneurysm treatment modality should be preferred. And I think that is already a major step forward, because that is the difference between ruptured aneurysms, where standard coiling is the treatment of choice for most locations. Then flow diversion as a primary treatment strategy. This was quite surprising according to the data, but yes, it should only be considered in patients where there's no other endovascular or surgical option. And I think that should be mentioned in interdisciplinary discussions, that a 3 or 5 millimeter MCA aneurysm that can be surgically treated should not be, for instance, treated out of your hip with flow diversion. Then numbers. And I think we see more and more quality standards. So there should be an interdisciplinary discussion. This is one expert consensus statement. And aneurysm patients should be treated at centers that see, and I mean not only treat, but also follow about 100 patients per year with ruptured and unruptured aneurysms. But the treating physicians should also treat more than 30 patients per year, ruptured or unruptured aneurysms. And this was already a strong consensus across the group. Then follow-up imaging. So aneurysms that are considered at some point for treatment should be followed if they won't be treated immediately. If you're not going to treat an aneurysm, then probably you shouldn't. I mean, what I mean is, if there is a contraindication to treat an aneurysm also in the future, then probably you shouldn't follow it. Meaning an 82-year-old patient that won't be treated anyway probably shouldn't be followed. And however, if an aneurysm grows, and this is not a step back, but this was in combination with follow-up, the PICO on follow-up, if an aneurysm grows, then treatment should strongly be considered. Moving towards medical management and lifestyle modification. And I will get to this in a second. We do not suggest at present, despite all the data that is out there, to start treatment with acetylic salicylic acid with the intention to decrease the risk of rupture or growth. The same holds true for statins. However, we also don't say that we should stop aspirin treatment or platelet aggregation inhibitors if there's a medical indication, if an aneurysm is present in that same person. And this was again expert consensus, the treatment target for hypertension should be lower than 130. So then follow-up after aneurysm repair, we suggest one initial scan within 3 to 12 months after UIA repair. And now we suggest MR angiography for primary imaging in endovascularly treated aneurysms and CTA. And I mean also more sophisticated CTA, meaning force CT, for instance, for microsurgically treated aneurysms, because you cannot assess artifacts in an MRA anyway in such patients. And if there's doubt, a DSA should once be performed anyway in both cohorts. So for the last 10 minutes, I will speak about unresolved clinical questions, and that is medical management of unruptured aneurysms, the topic of small UIAs, meaning less than 5 millimeters, vessel wall imaging, and other biomarkers. I won't speak about genetics of aneurysms or familial aneurysms just because that is not my primary expertise, and other colleagues are way more competent than me to talk about this very big topic. But of course, at present, we don't have strong genes suggestive of a aneurysm disorder in, for instance, familial aneurysms. But there is, of course, associations in those large DWAS studies. Then sexually related difference in UIA prevalence and rupture risk, meaning women at increased risk to develop an aneurysm or develop a subarachnoid hemorrhage. So medical management, and this is data from a meta-analysis that our group published a couple of years ago, where we looked at the incidence of subarachnoid hemorrhage globally and looked at time trends. And the incidence of subarachnoid hemorrhage has significantly decreased over the past 3 decades. And this is this dark blue line, if you want. And interestingly, and this was associated with systolic blood pressures in the underlying populations, and this was sex and age adjusted. This was in parallel to systolic blood pressures in the underlying populations where blood pressure was treated more effectively. And again, for smoking, there's also an interesting association with decreasing smoker prevalence in the underlying studies. This means in absolute terms that if you decrease the systolic blood pressure by 1%, the incidence of subarachnoid hemorrhage in the underlying populations decreased by 7.1%. And for smoking, with every decrease percent in smoking prevalence, there was a 2.4 decrease SAH incidence decrease. So that was across all the other data, our impetus to pursue a medical management study in aneurysm patients. And this was also underlined by data from, for instance, David Hassan's group that was able to show that aspirin treatment in unruptured aneurysm patients, and this was a nested case control study from the Israel data set, so no RCT, but really a nested case control study. Aneurysm treatment in such patients, meaning 3 or more times a week, had a significant lower odds for aneurysm rupture in these patients. And this was also confirmed in a small phase 1 RCT from David Hassan's group with a surrogate for aneurysm wall inflammation. And why aspirin? Because of course it's an anti-inflammatory drug which results in a radiological and histological reduction of aneurysm wall inflammation. And this is also supported by population-based studies from this group that showed in SAH patients a aspirin treatment longer than 1 year reduces again, significantly the incidence of subarachnoid hemorrhage. So these data were the impetus to develop a RCT in aneurysm patients that do not require preventive aneurysm repair. And we were targeting aneurysm wall inflammation and hypertension. I showed you that aspirin is beneficial because of unselective COX inhibition. And this is the PROTECT-U trial that is still ongoing. It's a phase 3 trial. It takes place at different centers, including Mannheim, Göttingen, Berlin, Freiburg, etc., in Germany and the Netherlands, and now also in Canada and soon in Finland. And the intervention is low-dose aspirin treatment and intensive blood pressure reduction versus standard of care, which is normal blood pressure reduction. And this was the patient that I showed you with the breast cancer. So she is well regarding her breast cancer. And this is the 3-year-old follow-up under the experimental treatment within PROTECT-U. And you could see that the aneurysm is still stable and the patient is well also regarding her malignant disease. And so we randomized 284 patients. We still have a long way to go. And I'm hoping, of course, for more centers and more patient inclusion in Finland. And if we get more money at some point, we open also other countries. So let's speak briefly about vessel wall imaging, because that's an important topic. And to summarize, yes, there is an association between circumferential wall enhancement in contrast enhanced MR angiographies. And that is a potential marker for aneurysm instability, because unstable aneurysms have a higher risk for rupture or growth. And this is also underlined by data from Miriam Ajali in a follow-up paper, where she showed that aneurysm wall enhancement decreases under steroid therapy for other conditions. And there's a nice review by David Hassan's group on vessel wall imaging. Again, I'm not very competent to speak about these studies because our center doesn't do it. But it is interesting if you look at this modality, which is QSM imaging. And this was from the Iowa group. And it shows essentially iron remnants around an aneurysm. And this could be in combination with myeloperoxidase gadolinium enhancement, an interesting surrogate for aneurysm wall instability. We are currently investigating a new biomarker based on our collagen studies. And I cannot go into too much detail because this is preliminary data, but at present, we see collagen products in peripheral blood in patients that have an aneurysm compared to aneurysm that don't have an aneurysm. So I'm hoping to show you more in a couple of months. And this is an ongoing study within the PROTECT-U study called Continuity, and it investigates collagen turnover and inflammation in these patients. So briefly, as a final topic, small aneurysms. And this was a really painful story for myself. This was a young 34-year-old female that came to our hospital and because of a rupture from this very small MCA aneurysm with a distinct hematoma. She had a quite difficult clinical course with DCI, but she actually did well at 1 year. And she then developed on aneurysm follow-up, radiological follow-up, another aneurysm, this de novo aneurysm, and also this here. So also another diseased vessel, and the primary aneurysm was here. She was treated for that aneurysm with a bypass procedure. And we thought everything's well, but she had this tiny aneurysm on the contralateral side at follow-up, and we decided to not do anything. It was 2 millimeters large. And then she came back a couple of months later with this devastating subarachnoid hemorrhage from this aneurysm that had grown significantly. So to conclude, aneurysms are highly prevalent in the normal population, in the adult population. The rupture risk is multifactorial and incompletely understood. Unruptured intracranial aneurysms differ from ruptured intracranial aneurysms, and ISAT cannot be applied to this population. Cures can be applied, but this is interim data. The treatment risk of unruptured aneurysms, clipping or coiling according to cures, is about 4%. The risk is higher for more complex intracranial aneurysms or new devices. And it is important to detect growth on aneurysms that we choose not to treat initially. And lifestyle modification is a strong therapeutic target for patients that do not require immediate aneurysm repair. And I'm at the end of my talk. If you have further questions, you're always welcome to email me, or if you're interested in working with us scientifically. I appreciate the invitation by Professor Veit Rode and the ENS-CV section to talk about this topic. Thank you very much.
Thank you, Nima. Hopefully the connection is better now, so I'm better hearable.
Yes.
I was not able to say at the very beginning that if you have any questions, please put them in the questions and answers section, and then we can go through it. So if you have any questions, just put it into this section. And for a sort of warm up, I have personally a few questions. You talk about the flow diverter and your recommendation that flow diverter should not be used if you have the chance of coiling or clipping. But in my opinion, it also depends on the location of the aneurysm. So why this was not considered in the recommendation?
So you're absolutely right. And to be honest, Veit, this is, of course, a difficult topic because we have many data from industry-sponsored studies that suggest that flow diversion, at least in the short term, is somewhat effective. And I agree that location is a strong determinant, but frankly, we were not able to further distinguish this in the consensus format, you know? So I think everyone was on board that if an aneurysm is coilable or clippable, and clippable, of course, with a rational approach, but then flow diversion should not be the primary treatment strategy. But I think that is one step forward, but not the ultimate solution. I agree with you.
Yeah, the thing is that you must be, it's different what you consider to be clippable and what another neurosurgeon defines being clippable. So let's say a supraophthalmic aneurysm is clippable, but it has a quite higher morbidity, surgical morbidity. So in this context, possibly a flow diversion might be an easier solution.
Yeah, I'm smiling because we recently had a debate regarding exactly those aneurysms. And in a young patient, I'm not completely sure if it's a saccular aneurysm, if the disease is, if the segment is completely diseased, that's a different thing, right? And if there's a visual disturbance, it's also a different thing. But you're right. I mean, that is a very good indication if all the other factors are respected.
Your talk must be very big because there are no other questions from the audience. So, but I go on a bit with a few questions, and possibly someone would like to also ask a question. You showed the the study in which the coiling and the clipping was compared in the unruptured aneurysms. And your summary was that, let's say, the results had been quite the same. But at the bottom of the table was the rates of incomplete clipping and the rates of remnants. And I think there also had been a difference. It was not a statistically significant difference, but there is a difference. Which do you think
mean this slide?
Possibly, yes, might play a role if you have a longer follow-up?
Hold on, I cannot see my own slide because this chat window is open.
Okay, so I can read your slide.
Sorry. Yeah, I can see it. So you mean this here?
Yes, exactly.
Yeah. So yes, you're right. Completely correct. And that is what we know, right? And if you treat an aneurysm, you should treat it with the intention to completely treat it. However, I have to be fair because, of course, I'm biased as a neurosurgeon. The patients with new neurological deficits were higher initially. That doesn't constitute to a significant morbidity at 1 year, but there is also here a difference, right? And probably that is exactly what you mentioned, that, for instance, supraophthalmic aneurysms. I should mention that this was not only coiling, it was any endovascular treatment.
Okay. I have a question also concerning the, let's say, new MR imaging sequences, the black blood sequence, what we are using. And yeah, we tried it, and we have used the black blood sequence for follow-up investigations. And now I'm very hesitant because we have had one case of a, let's say, a larger M1 aneurysm. I think that the neuroradiologist told me, oh, there is more contrast enhancement. And I think it was not standardized, the amount of contrast medium given at both investigation time points or the timing of the investigation, which means that I thought it was more contrast medium, but everything was more contrast medium, and this suggested a bit it's an unstable aneurysm, and therefore I think at least we must be very, very careful with these black blood sequences and the consequences which might arise from these imaging. What do you think?
I agree with you entirely, because I think we don't know what we're measuring, and there's no standardization with meaning different stages, right, in one patient. So, and if you base your decision on that per se, then that's a thin topic. Also in the guidelines, we weren't able to formulate a recommendation here because there's simply not good enough data. And we don't know what that means at present. Is it just pile enhancement, or is it really blood products, or what is it? So I agree with you.
Okay, so I stimulated a bit the audience, and there are at least 3 questions from the audience. Very good. There's one from Dr. Leber. He would like to know if there are any negative influence of ciprofloxacin on aneurysm rupture.
I have to think 1 second, because minocycline is...
No, ciprofloxacin?
Yeah, I know, but I don't know if there's a cross connection, because I don't think that ciprofloxacin has a negative influence on aneurysm rupture. But it's actually the opposite, that some antibiotics, because of MMP inhibition, and that is minocycline, have a positive, like, protective effect of aneurysm rupture. Okay,
very good. There's another question. What's your opinion on recent studies that look at CSF and serum interleukin 6 and 8 as potential biomarkers for unruptured aneurysms? And do you think other immunological inflammatory markers are suitable biomarker candidates?
Yeah, so I think the interleukin topic is a difficult topic because somehow any interleukin is associated with a given disease. And I'm not sure how sensitive that is at this stage. I think we need a biomarker, but there are at present no strong biomarkers, especially inflammation, because also the data that I showed you from our own group, because for instance, if you just look at one molecule, it's not exclusive to aneurysms in patients, and inflammation at IL-6 and IL-8 can also be increased in other diseases in the same patient. So it's difficult, but we have to focus on that as a target.
Yeah. So you mentioned the wall shear stress and all. There have been a hype about the wall shear stress, I would say 10 years ago, 12 years ago. But as far as I can remember, so the results have been a bit contradictory. And is there now a clear line which parameters play an important role in a negative or a positive way?
No, it's still the same. And I think we need more biological data to support CFD, so computational fluid dynamics. And wall shear stress, as you said, our study showed that high wall shear stress is increased with high collagen turnover and aneurysm instability. Other studies showed exactly the opposite. And I don't think that there is one type of aneurysm. And I think you know it as a surgeon yourself, Veit. There's aneurysms that are arteriosclerotic and are quite thick, and aneurysms that are translucent and quite thin and small. So probably there's different populations where these parameters have a different signal.
Okay. There's another question from the audience. And the question is difficult. What is the reason to take the number of 100 aneurysms per year to be a center?
Yeah, you're right. It's completely arbitrary, but we had to start somewhere. And I think it's important to talk about minimum numbers because centralization of care plays a role in most European countries. And this was the consensus across the group. So 150 is too high and 50 is too low.
Okay, and how do you just try to quantify the quality of the neurosurgeon and the quantity, the quality of the neuroradiologist? Because that's one very complicated topic, and it's also quite complicated that in a neurovascular center, I think both should have a high quality, which is not always guaranteed. So you can be a cerebrovascular center with quite a high number, but if there's difference between the quality of the neurosurgeon and the neuroradiologist, it's still not the ideal situation.
I agree. This is why we introduced another benchmark, which is 30 aneurysms per operator per year. And it's irrespective of modality, but you're right.
Okay, I don't see any more questions from the audience, which also might have been related to the fact that the connectivity with my computer was so low at the beginning, so I could announce in advance to raise a question, put it in the question and answer section. But nonetheless, I think it was a beautiful talk. We learned a lot. And I'm very grateful that you gave your talk during your vacation in Italy. I think normally during this time it's better to drink something than to give a webinar. I'm very grateful, and I think the audience is very grateful that you have done it, that you have realized it. And I hope to see you soon in Belgrade or somewhere else. And I hope to see the audience or to be in contact with the audience soon for the next webinar of the ENS vascular section. Thank you. Bye.
Thank you, Veit, again for the invitation, and again apologies for missing my previous appointment with you, but that is how it is as a surgeon. Thank you very much for the invitation.
Bye.
Bye.